ERT and how to prevent them. Over to you, ma'am. So we had some questions posted before we started the class. We'll have a discussion on it maybe
At the
I mean,
end.
I'm sure
Yeah.
everybody of you will know the answers once you listen to Dr. Abha, ma'am.
So thank you again, Tejashri, for being there and getting pushing me off to get kick started for another lecture. Today I thought I'll take high order multiple pregnancies in ERT. Last 2 months, I've seen devastating cases of multiple pregnancies outcome. And it's just 2 months that these three cases were referred to us. Mrs. X had IVF, 3 embryos transferred, triplet pregnancy, fetal reduction to twins at 16 weeks, followed by cervical cerclage at 17 weeks. She started with intractable fever, UTI, and went into septic shock with a total leukocyte count of 60,000. She was transferred to a tertiary care center from the IVF center where she was being treated. This is just about 40 days ago. She progressed to acute kidney injury. A kidney biopsy showed cortical necrosis. Currently, she is on dialysis every alternate day to keep her going. She was put in the ventilator and her ICU stay started for 21 days, continued for 21 days in that tertiary care center. Then she had a spontaneous abortion during all this and had to go through DNC twice. And the DNC had to be very vigorous to make her stop bleeding and probably landed into Asherman by now. Fever is still persistent. Now they've planned for hysterectomy in view of a TO mass as possible source of infection. This patient's mother and brother came to me with all this history and said, "We want to save her uterus. Can you do something? We will transfer her under you." But then in the meantime, they found that there was pericarditis also for this girl. So surgery was postponed and her pericarditis is being treated. I don't know what happened to her. Did she go through hysterectomy? This parent, mother, and brother came to me just about 7, 8 days ago with the whole history. And I thought, oh my goodness, look at this girl, young girl, 28-year-old, went for IVF, and this is what she turns her life into. And another case, just about 10 days before that came to us, this was a 44-year-old lady who already had chronic hypertension, type 2 diabetes mellitus, and hypothyroidism. That means she had full-fledged metabolic syndrome, 44 years. IVF was done in view of advanced maternal age and low ovarian reserve. And donor donor eggs were used to create embryos for her. 3 embryos were transferred in this 44-year-old lady, and there was a triplet pregnancy. Fetal reduction was done at 12 weeks to twins, and cerclage was applied at 17 weeks. She was referred to us at 27 weeks with intractable hypertension and intrauterine death of twin B. And then we managed her conservatively till 32 weeks because we at least wanted to save one child of hers. But then at 32 weeks, we had to do a cesarean section because there was oligohydramnios and the CPR came down to less than 1. When we opened her, one fetus was prepacious, second was dead, and the third was a 1650 grams live baby, which was shifted to neonatal nursery. In the NICU stay, they found that this child had total anomalous pulmonary venous connection, whereas her level 2 scan was normal. There was no fetal echo which was done for her. She also had patent ductus arteriosus. She was kept on SIMV mode of ventilation and 3 doses of surfactant was given. SIMV mode of ventilation is known as synchronized intermittent mandatory ventilation. This child underwent cardiac surgery at 45 days. We have a very good cardiac unit and cardiac surgeon is extremely good, the pediatric cardiac surgeon. She was discharged on day 60 from NICU, having paid a huge bill. So this is what happened to this 44-year-old lady with 3 donor egg embryos transferred into her. Then we come to one more case. Oh, why is it not moving? Yeah. Case 3 is again Mrs. X, 39 years old, IVF done for advanced maternal age. Again, 3 embryos transferred and she conceived twins. Now look at the course of this lady. She presented to us at 26 weeks. She was not in Delhi. She came from another city. I'm not disclosing any names. She came with severe preeclampsia and IUD, intrauterine death in twin B. That is how she was transferred. DEXA cover was given. BP was managed on 5 antihypertensives. I have never seen such high doses being given to anyone. Labetalol was used as 400 milligrams 4 times a day. Clexane was given in view of IUD to probably save the other twin, and daily injection albumin was given due to very high proteinuria. She went into, we could only pull her through 4 weeks. She went into cardiac failure at 30 weeks, had pulmonary edema. We gave her MgSO4 and emergency cesarean was done under general anesthesia because she was in a bad shape. First twin was a live girl, 750 grams. Second boy was IUD, 450 grams. This lady stayed in surgical ICU for 3 days and was discharged on day 9. This baby was on SIMV mode of ventilation. She also received 3 doses of surfactant. There was respiratory acidosis. She was shifted to HFOV mode of ventilation. I'll just tell you, high frequency oscillatory ventilation. And after that, this child on day 10 of life went into shock, and this was septic shock. Despite maximum inotropic support, baby continued to be in shock. Sepsis workup was done, antibiotics revised, but baby deteriorated. And despite cardiopulmonary resuscitation, went into arrest on day 16 of life. So this lady lost both her babies at 39 years because 3 embryos were transferred for her and she conceived twins. Having said that, I thought, let us look what is happening in the whole world. I mean, 3 cases in 2 months, which such bad prognosis, and all cases of multiple embryo transfers. The 1995 ART World Report said that multiple birth rate has gone up to almost 30%, with twins about 25%, and the remaining triplets and quadruplets. Whereas in general population, the incidence is only 1.1%. Triplet is even less. So we understand that although a very small proportion of population undergoes infertility treatment, these are the ones who desire a baby, a live birth. They don't want to lose their lives to get that child. The increased risk of multiple gestation of this group has an impact on national multiple gestation rates. Having said that, I bring you to what happens in multiple pregnancy. There is maternal morbidity and mortality is higher, and you all agree to it. Risk to fetus is several fold. Preterm and very preterm is major cause of neonatal mortality and morbidity. Risk of lifelong neurological problems of these preterm babies who have spent a lot of time in nursery. Rearing difficulty for parents. They have delayed milestones. They have other developmental problems. And health service cost goes up. All these parents maybe spend 2-3 lakhs on IVF, and just to save the baby, they spend 10-15 lakhs, still not knowing whether this child will live or not. Now, let us come to 2 basic things about twinning. One is zygosity and one is chorionicity. What is a monozygotic twin? It is splitting of one fertilized ovum during the first 2 weeks of embryogenesis. And the rate of monozygotic twinning naturally is fairly constant, which is 3 to 5 per thousand births. Dizygotic means 2 ovae, 2 spermatozoas. This twinning is affected by race, hereditary, maternal age, ovulation induction drugs, and the use of ART, whether it is IUI or IVF, because multiple eggs are released and each egg is fertilized by one single spermatozoa. And hence, these are dizygotic twins. The Helen's law for higher order pregnancy is Twins naturally in the world happen 1 in 89. If we go to triplets, 1 in 89 square, and quadruplets is 1 in 89 cube. So that is how high order pregnancies normally happen in the world. Mechanism of twinning, this is a very nice diagram which will show, it shows two things, dizygous and monozygous. Monozygotic, dizygotic. Twins, 70% are dizygotic, 30% are monozygotic. Dizygotic twins are these which have two babies and two placentas. Dichorionic, diamniotic. Now, in monozygotic, what can happen? If the split is very fast, by the time you're transferring an embryo within 2 days, there is split, it will be a dichorionic, diamniotic baby. But if the split is in 3 to 8 days, then it becomes monochorionic diamniotic. There's still two amnions, but the chorion is all fused. And then if the split is even later, that is, the baby is implanted and 9 to 12 days the split happens, then it may become a monochorionic, monoamniotic twin. And if the split is after 12 days, then these are conjoined twins, which are very rare. So monozygotic can be dichorionic, diamniotic. Dizygotic are always dichorionic, diamniotic. Just remember that. So if we see chorionicity or placentation. So chorionicity means placenta. There are two different placentas. It's all joined into one. So dichorionic happens in 80% of twins, 70% of dizygotic twins, and 10% of monozygotic also become dichorionic. It can happen in, as I said, monozygotic or dizygotic, separate or fused. Monochorionic happens in the remaining 20% of twins. Only monozygotic can be monoamniotic or diamniotic. This is clear according to when the division has taken place. So zygosity and chorionicity, one egg twins are these. One egg twins means there is one chorion generally, and if it's a late split, and there's two amnions, whereas two egg twins will have a complete chorion amnion surrounding each twin. Come to another interesting part, that how do you diagnose chorionicity? 10 to 14 weeks is the best time to diagnose. The twin peak sign, also known as the lambda sign, is a triangular appearance of the chorion insinuating between the layers of the intertwin membrane and strongly suggest a dichorionic, diamniotic twin pregnancy. It is best seen in the first trimester between 12 to, this is it, insinuating inside. Facts about multiple gestation, it is chorionicity rather than zygosity which determines fetal prognosis. Monochorionic twins, that means one placenta, are at a higher risk than dichorionic twins where there are two different placentas, whether they are monozygotic or dizygotic. Mortality is higher in identical twins, so it has to be monozygotic twins. Highest risk to twins before 24 weeks and of at least one twin loss is known. 12% of monochorionic and 2.5% of dichorionic. Triplets or higher order can have a mixture of chorionicity. So maternal mortality and morbidity. Mortality, let me bring you to mortality. These are mothers who die because of multiple gestation. A Nigerian study said 1% for singleton, 2 for twin, and triplet it goes up to 3 times higher. In Europe in 1994, they said threefold increase in maternal mortality rate. The maternal mortality rate is really low, not like ours. Ours, even singleton pregnancies lead to a high maternal mortality. So multiple would lead to much higher. And the causes of maternal death are eclampsia, excessive blood loss, pulmonary edema with beta mimetic tuberculosis, which is so common. All these women are receiving this because they threaten to have preterm labor. So I took this chart, which shows maternal morbidity. So I spoke about mortality, which is very high. It is almost 3 times higher than that of twin and high order pregnancies and double in twins. Spontaneous abortion, hyperemesis gravidarum, anemia, congenital anomalies, all of this is much higher in twins versus singletons. Monochorionic is much more than dichorionic gestations, and it increases in assisted reproductive technology. And anemia happens because plasma expansion is greater and averages to 50 to 60%. Now, second and third trimester complications, this is what I want you to see. Gestational hypertension, preeclampsia will occur more readily. A 40-year-old woman, if carries twins or triplets, is much likely to to suffer from gestational hypertension, preeclampsia, diabetes, placental abruption, acute fatty liver, placenta previa, postpartum hemorrhage, uh, and then IHCP and pressure symptoms are always there. The mother is so uncomfortable because increased uterine enlargement, hemorrhoids, varicosity, dyspnea, pedal edema. So I took this from the latest chart which came in the ESHRI guidelines. And this said, like you can see, cesarean delivery, this is risk with transfer of more than one embryo, risk with SAT. So more than one embryo, 455 per thousand, this goes up to 755 per thousand. Gestational diabetes is 89, this goes up. Preterm labor goes up 4 times. Pregnancy-induced hypertension goes up double. Preeclampsia double. Preterm birth goes up 3 times higher. NICU admission is like almost 4 times higher. Perinatal mortality is almost 3 times higher. So all this becomes very high, and the certainty of evidence is of high grade, especially for cesarean delivery, gestational diabetes, pregnancy-induced hypertension, and preeclampsia. Congenital anomalies also is much more in twins versus singletons. You can see that figure written here. Monochorionic risk is 3 times higher than singletons, and dichorionic risk of each fetus is same as a singleton, that is 2 to 3%. What are the problems with monochorionic twins? Unequal distribution of cell mass or cleavage. One baby could be smaller, one baby could have a bigger cell mass, and vascular events due to anastomosis between the vessels of the two babies during embryogenesis. So cardiac anomalies happen in monochorionic twins 4 times more than general population. Skeletal deformities, midline defects, holoprosencephaly, and neural tube defects. So monozygotic are most exposed to it, but what we are creating is dichorionic, dizygotic, which also have a very high risk. So fetal and neonatal outcomes, I already told you about congenital malformations, also chromosomal anomalies with marginal increase in Down syndrome, discordance in birth weight. Twin-to-twin transfusion syndrome is a very big complication, may happen in 5 to 15% of cases, and neonatal morbidity due to higher rate of preterm birth. So I just want to bring to you now, after saying all this, we're now coming to our real subject, that there is no difference in outcome seen with respect to mode of conception, that is with spontaneously occurring multiple gestation, or with ovulation induction, or with IVF. Here I want to bring to you 3 instances where we induce ovulation and there is a high risk of multiple ovulation. Ovulation induction for women who are not ovulating regularly, like PCOS. Or when you plan IUI, then our aim is to have at least 2 dominant follicles. And when we plan IVF, there is no limit. We can have 10, 15 follicles to create so many oocytes. So in ovulation induction and IUI, conception occurs in vivo, so there is high chance of risk of multiple pregnancy on multiple ovulation. IVF, if we give an antagonist cycle, agonist trigger, freeze the embryos, then IVF is the only method of conception where we can avoid a multiple pregnancy by leading to one elective single embryo transfer. So aim is to have a single live birth only. Nobody wants twins to come together. You don't enjoy the children also when you have twins. There's so much burden. IUI, IVF both require ovarian stimulation. I have a question for all of you. Ovarian stimulation for ART can lead to OHSS and multiple pregnancy, and you all agree with this after listening to whatever I had to say. Can these complications be prevented in IUI and IVF? Tell me. In IUI, you can't prevent them. In IVF, you can prevent. And we are talking about IVF today. So let us prevent these complications. if you are in standalone clinics or you're not in hospitals which are referral centers, you don't see the consequences of these multiple pregnancies. They don't reach to the stage of live birth. The parents spend so much money, still take a neurologically handicapped baby home if they take. So I looked into the review, and very early Cochrane review in Human Reproduction 2005 said that pregnancy rate with elective uh, to embryo transfer is almost equal to pregnancy rate with elective single embryo transfer plus one FET. So here also you're transferring two embryos, but you are doing one single two embryo transfers in 2 times, whereas you're doing a double embryo transfer. Conclusion was single embryo transfer significantly reduces the risk of multiple pregnancy, but it also decreases the chance of live birth in a fresh IVF cycle. Therefore, subsequent replacement of a single frozen embryo achieves a live birth comparable with double embryo transfer. So this is in the time when fresh embryo transfers were done a lot. This is a paper published in 2005. So it had data from the 90s and early 2000 only. Our data, I thought, let me bring you our data. For last 5 years, we are doing elective single embryo transfer. And since we had the live birth rate of 2022, we looked at all the frozen embryo transfers and fresh embryo transfers. 977 embryo transfers were done. Out of that, single embryo transfers were 800, which is 81%. Don't even talk about positives live birth. Let us only look at live birth rate was 38.7% with positive beta HCG 57.7. And in this group, we had only 2 twins, which were monochorionic twins, where the embryo split into two. Where we did double embryo transfer, again, the transfers were only 18%, 18.1%. Positivity rate was again same. That was 57. This was 54.8%. And live birth rate was 32%. So in single embryo transfer, we did not find lower live birth rate. And here we had 30 singletons, 24 twins. Look at the twinning rate and 3 triplet, almost equal, 50% twins and triplets and 30% singletons. This is because our implantation rate is very high. It has reached the benchmark of implantation rate, which is about 60%. If we look at the key performance indicators. And hence we get such a high twinning rate if we do a double embryo transfer. So we are now almost reached a stage where more than 90% are being single embryo transfer. Question your embryologist. Let the embryologist take out the data for every single embryo they give us. And let them give us the right numbers at how many implanted. If they gave us 3 embryos, and none implanted means implantation rate is 0. If they give us 3 embryos and 1 implanted, implantation rate is 33. Get the average out, push the embryologist to make better embryos, and we will be able to reach a stage where we can do SCT with comfort. Now, I'm looking at the American Society for Reproductive Medicine, which was published in first 2017 and then 2021. And I only took out the gist. What do they say? Recommendations for number of embryos to be transferred. Euploid embryo, only one should be transferred regardless of age. But they say up to 37 years of age, strong consideration for single embryo transfer. 38 to 40 years, 2 or less blastocysts if they are self-oocytes. If they are cleavage stage embryos, then you can transfer as much as 3 untested day 3 embryos. After 41, if you've not tested the embryo, and these are all self-oocytes, not donor oocytes, it's very clear if donor oocyte is used, only SCT to be done, whatever the age may be. So they say that you can transfer up to 3 blastocysts. Now, why have they made this figure as 2 and 3? Because the aneuploidy rate becomes higher and higher after 38 years. Other scenarios in the American ASRM guideline is patients who do not achieve a pregnancy in multiple cycles may have an additional embryo transferred according to their individual circumstances after counseling risk of twin or higher order multiple pregnancy. Patients with a coexisting medical condition with increased risk of significant morbidity should not have more than 1 embryo transferred. If they are diabetic, hypertensive, obese, or they have any type of morbidity, please do not transfer more, because that morbidity is going to go skyrocketing high. And if the number of embryos or blastocysts transferred exceeds recommended limits, justification must be documented in the patient's permanent medical record that we transferred this. If this lady loses her baby, you have a record that this is with the patient's consent that I transferred 2 or 3 embryos for her. Now, I'll show you the ESHRI guideline, which came out in February 2024. This is the latest. And what do they say about the number of embryos to be transferred during IVF ICSI? They say if you do a single embryo transfer for the mother, it is safe pregnancy and a vaginal delivery is a good possibility. There would be reduced preeclampsia, gestational diabetes, emergency cesarean, and preterm labor. For the babies are generally full-term birth, healthier childhood, and there is reduction of prematurity and developmental delays. Then we look at society. Society comprises of healthier children, healthier families, and less financial burden. And when we look at the family, then interaction with the child increases of everyone, because there's one child to be looked after, and there is less of exhaustion, psychological burden, sick leave days, and financial strain. Having said that, ESHRI guideline says increasing success following ART has been accompanied by concerns about high rate of multiple pregnancies with increased risk of obstetric and neonatal complications, along with miscarriage, preeclampsia, prematurity, low birth weight, and perinatal mortality. Single embryo transfer is recommended to reduce the complication rate of multiple pregnancies following ART. Which issues should be considered before we transfer more than one embryo? So ESHRI is very clear. Only one embryo, all Europe is clear about it. Only one embryo transfer, but there are certain conditions where you would transfer more than one. Medical risk to be considered before transfer of more than one embryo, because it leads to higher rate of maternal fetal neonatal complications, and it's got a strong association. If transfer of more than one embryo considered, provide clear information to the patient about higher risk of pregnancy loss, higher risk of ectopic and heterotopic pregnancy, preeclampsia, gestational diabetes, antepartum and postpartum hemorrhage. And I know how we control the postpartum hemorrhage of that girl whom we had to deliver, who was in cardiac failure at 30 weeks. There was no way her uterus would contract, because she was on like Dipin, high doses of Dipin for so long that her uterus did not know how to contract. We had to close a non-contracted uterus. Cesarean section, stillbirth, preterm birth. You've just seen 4 stillbirths in these 3 pregnancies, which I described, of multiple gestation. Low birth weight, neonatal intensive care admission, neonatal death associated with multiple pregnancies. And the guideline development group recommends patients sign an additional consent form if more than one embryo is transferred. And we do this in our center when after 2 failures, the patient comes and says, this time I want 2 embryos. We make them sign that you want 2 embryos, and you should be aware that if both the embryos implant, these could be your complications. Financial issues have to be explained, and psychological issues have to be explained, and emotional distress has to be explained to the patient. Now, which criteria should not be used when deciding between double embryo transfer versus single embryo transfer? Previous unsuccessful ART treatment. So look what a wonderful thing they say. If she's had 1 failure or 2 failures, you don't increase the number of embryos that, oh, maybe you will conceive now, I will transfer 3 blastocysts this time. Previous pregnancy or having no live birth before, having an abortion before, again doesn't qualify us to transfer more than 1 embryo if her age and general condition is good. Duration of infertility, she may be 15 years infertile, but if she's still in the age group where you will want to transfer one, please transfer one. And then ESHRI guidelines does not recommend more than 1 embryo transfer, whether the woman is less than 38 or more than 38. So this is the difference between ASRM and ESHRI guidelines. ASRM agrees to 2 embryos transferred after 38, but they have to be self-oocytes, not donor egg. Donor egg, everywhere there is only 1 embryo transfer which is recommended. And the only reason why they agree for 2 embryo transfer is because of the high aneuploidy rate in maternal high age. Ovarian response may be less or more. You don't transfer 2 embryos because the response was less and she makes less embryos, so I will transfer 2. Endometrial characteristic in fresh and frozen transfer cycle. Here the lining is 7, so I'll transfer 2 embryos and the lining is good and I'll transfer 1. That's not a criteria. Whatever the lining is, your mind to transfer 1 or 2 should be made according to the patient's characteristics. Treatment with donor oocytes and donated embryos, only elective SCT for patients undergoing ART. And gestational carriers, that means surrogates, only single embryo transfer. These are very strong recommendations. They do not allow double embryo transfer. If a complication happens to anyone who's carrying a pregnancy, a twin pregnancy with donor egg, in a woman who's 40 years old or a gestational surrogate, gestational carrier, you can be sued by their guidelines. ESHRI guideline, number of embryos to be transferred. So decision to perform double or single embryo transfer should not be based on female age. Women aged less than 30 years should receive SCT. Women aged more than 30 years should receive SCT. And the association is strong, strong, strong for all of these. Embryo criteria. So this was age criteria. Now you say in fresh embryo transfer, you're looking at fresh cleavage stage embryo transfer. Day 3. You will not decide double embryo transfer on embryo grade or criteria. If the embryo is low grade, you say, I will transfer 2. If the embryo is high grade, you will transfer 1. No. If the embryo is of any grade which is acceptable for cryopreservation and transfer, you will transfer only 1. Fresh blastocyst transfer, same thing. You will not look at blastocyst morphology and quality and say, I will do 2 transfers instead of 1. In frozen embryo, they have recommended that you will only cryopreserve 1 embryo per freezing device in order to facilitate the practice of single embryo transfer and traceability purposes also. If a child has abnormality, you know what was this embryo looking like. And then again, cryopreserved cleavage stage embryo transfer decision is not on embryo criteria. Same way, vitrified blastocyst transfer cycle, SE to be a single embryo transfer to be applied regardless of quality of blastocyst. You think the quality is poor. We thought once the quality was poor for a consultant and we transferred 2 embryos. That poor girl who was a very good doctor had to carry twins all across 9 months. So we thought it was poor quality, but both the embryos implanted. So whichever quality you think is fit for freezing and is fit for transfer, only 1 embryo transfer should be made. And transfer of more than 2 embryos is absolutely not recommended by the ESHRI guidelines. Now, you always know that there is a option of embryo reduction. So if I transfer 3 embryos, maybe only 1 or 2 will implant. But if all 3 implant, then I can do a embryo reduction. So what is the guidelines for this? In patients who conceived higher order multiples following multiple embryo transfer, fetal reduction can be considered to reduce the risk of maternal complications. This is a conditional observation, but transfer of 2 or more embryos with the intention of performing fetal reduction in case of multiple embryo implantation instead of doing elective single embryo transfer is not recommended. That you do more embryo transfer and say we will do a reduction, because the guideline development group recommends against the transfer of more than 2 embryos with fetal reduction after multiple embryo implantation, because there is high risk of the procedure also. And you've seen in 2 of my cases where triplet was conceived, they did they did a fetal reduction in both the cases, put a cerclage, and we lost the babies. We lost 1 twin in one and we lost all the babies in the other one. So to conclude, I would say, as there is no evidence showing the cumulative live birth in elective single embryo transfer is inferior to that in double embryo transfer, and as published data clearly demonstrates that the pregnancy rate, multiple pregnancy rate after DET is significantly exceeds that after single embryo transfer. You've seen in our case, the multiple pregnancy rate went up to 50% when we did DET in less than 20% of patients. So if the standard, whenever more than 1 embryo is available, please understand that E-set will lead to the same pregnancy rate, but a double embryo transfer will lead to a high multiple pregnancy rate. And the following condition warrants strictly the use of elective single embryo transfer. One is donor oocyte, donated embryo, recipients, gestational carriers, patients at risk of OHSS for whom a fresh embryo transfer is being planned. Never two embryos to be transferred. Fresh cycle blastocyst transfers, all to be done as single embryo transfer. Neither the stage of embryo development, nor its morphology at transfer, nor the ovarian response to ovarian hyperstimulation justifies double embryo transfer instead of single embryo transfer. Thank you very much. Yes. So
Thank you so much, Abha ma'am. As always, it was a very, very clear and non-controversial final answer to how what should we do about the number of embryos to be transferred in what
yeah,
cases.
I'll
Uh,
just bring one question here, that IVF is the only place where we can provide we can sort of prevent multiple pregnancy. In IUI, we cannot. In ovulation induction, if our ovulation induction is slightly stronger, also we cannot. So why not prevent it? But you know what? We need better implantation rates for the clinicians to feel confident that they will do a single embryo transfer and yet the patients will get pregnant. This is the catch in our country, where the implantation rates are still dwindling around 25-30%. The moment they come up to 50-60%, all our clinicians, I'm sure, with confidence, will be able to do a single embryo transfer. Yeah, Tejashree, now you go
yeah,
ahead.
right. So, ma'am, here we have few people asking, few girls asking us that when should then we be doing a double embryo transfer? Is there a situation where we should be deciding for a double embryo to be transferred?
You see, the American ASRM guideline advises double embryo transfer after 38 years of age. They say
That
that,
too, even
but
if it is
their
non-tested, if
own,
it's a where we don't
non-tested,
know
their own oocyte used embryo because of the aneuploidy rate. But we do not do it, and Tejashree knows it, that whether it is 40, 41, 42, as much as 44, we have done embryo transfers of women with only single embryo transfer, even with their own oocyte. Donor eggs, we can close our eyes and do a single embryo transfer. So DTs, maybe in young women where repeated embryo transfers have failed, you're getting recurrent implantation failure, good embryos, you don't know what to do, and then maybe you can undertake a DET. What do you say, Tejashree, Dr. Bhavani, anyone else?
I think, yeah, ma'am, in such cases, maybe to, improve the implantation rates,
No,
we
but
might think of
implantation is
doing
just not happening. This is implantation
that
failure.
has,
And Abhi, we've had a patient, Ashima, who went 4 single embryo transfers 4 times, and all of them failed. We've labeled her as recurrent implantation failure, but we still did not recommend to put in 2 embryos, because if she's got implantation failure, both will fail. So apart
right.
from this, I can't think of another reason except self-oocytes and high age women without any medical comorbidity. She's not hypertensive, she's not diabetic, and she's around 39, 40 years. Maybe with her own oocytes, non-tested embryo, I would do a DT, but I don't do it. I mean, one could do it.
Yeah, that brings us to the next question, which Dr. Priya is saying that on one side, we advise DET in advanced maternal age
Hmm.
and increase the risk of multiple pregnancy in already high risk females who are,
Yeah. So that
advanced
is
age.
why the ESHRE guideline has
So,
not advised DET in advanced age. They are
hmm,
very clear
they have
about it.
very
The ESHRE is
clearly,
it is 2024 February, ASRM is 21, 17 revised in 21. So nobody advises DET in advanced age. I feel that advanced age woman should never carry twins. It is the highest risk for her for every possible medical condition to arise in
so
pregnancy.
ASRM had come up with those guidelines in 2017, and now after that, ESHRE has come up very
2021, they
clearly with
revised. They revised it in 2021, but ESHRE has come up very recently in
very
February this year,
recently.
that they
And
say
very
not
clearly they
as
have
a,
mentioned
yeah.
it is a elective single embryo transfer that has to be done. Dr. Nisha is saying that previous myomectomy with a 41-year-old, should we do elective single embryo transfer
Yes,
for a blast
yes,
for an untested embryo? Of course,
yes,
yes.
yes. Never think of doing a double embryo transfer. She's had myomectomy. I mean, even though aneuploidy rates are high, you can do 3 transfers per her in natural cycles, one after the other. You will surely get a pregnancy if things are all right, if your embryos are good and the implantation rate is good.
Ma'am, Dr. Garima wants to know what's the incidence of multiple gestation with clomiphene
It is rare
citrate.
because clomiphene does lead to multiple follicle formation. In one
It
case, we
is.
had pentaplets. I just gave her 100 milligrams, just closed my eyes and gave her, and I suffered. I'll remember all my life. Very careful with clomiphene now. You
Ma'am,
remember
regarding
that case?
the, yes, ma'am, I do remember
Clomiphene
that case.
pentaplets. We had 2 cases,
Yes,
one letrozole plus a little gonadotropin.
nadotropin,
That
pentoplates,
we
and
had
one.
pentaplets, and once in clomiphene, we had pentaplets in the last 10 years, I think.
Ma'am, Dr. Nisha wants to know if sometimes the embryologist give us a early blast for
You know what?
transfer. So
Let
how
them
many of
grow
those
the
should we be
blast.
transferring?
Let them grow the blast. Let them find it expanding fully. It starts hatching on its own. When the embryologist gives us the embryo transfer catheter, he comes and tells us this is an expanded blast, this is a hatching blast, early blast. The chances of it not expanding, not hatching. I still remember that one of these days, just about 4, 5 days ago, there was a patient whose blastocyst did not expand, and we had to transfer her embryo transfer. Another blastocyst was taken out, was warmed, and then we did the transfer in the evening at 5 o'clock because they had to see that it expanded before they gave it to us to transfer. So you ask your embryologist that don't give me a early blast to transfer. Even freeze them when they've grown into full blast, even if it is day 6. You can't do a fresh transfer on a day 6 embryo, but you can do a very nice frozen transfer of a day 6 blastocyst according to how you do a day 5 blastocyst, Nisha. So I think just tell them that let it expand. You freeze it next day, freeze it on day 6, but don't freeze a early blastocyst. And if it is early blastocyst on day 5 when you're wanting to transfer, tell him to grow it more. Don't do a fresh transfer. Can you bring up the questions, Tejashree, which you put up? Tejashree?
Unmute myself. All of this, these questions got answered with your presentation, ma'am. I think everybody who has listened to your presentation carefully must have got their answers.
So
So if
I would
anybody
want
has,
everyone on this WhatsApp board of ours, you can just write your name and write the answers, and we'll look into your answers and see that you've understood everything well. Indumati Joy,
ma'am,
we don't advise blastocyst biopsy. You see now the ball is rolling against PGTA. It was very much in favor of PGTA with Scott's paper, Foster's paper in 2012. But now they're seeing that even biopsied embryos, which are euploid, do not implant, and a lot of mosaic embryos do implant. So, though embryo biopsy for aneuploidy screen is good in advanced stage, but then only feasible if you have enough embryos. If you make 5, 6 embryos, you do a biopsy, you'll find 1 or 2 normal. If you make 2 embryos only, blastocyst, where is the chance of doing a biopsy and finding aneuploidy? I mean, Garima, you will have the
ma'am,
presentation on my website after a few days, okay? We have to give it to our organizers. InTask converts it into YouTube presentation, and then I put it on my website. Then you can see it then.
Thank you, ma'am.
If there are no more questions, we can close the talk.
just one last question. Dr. Priya had asked about what about the embryo pooling some IVF centers do to collect two good quality embryos to transfer rather than a single embryo transfer.
Yeah, Priya, this is the problem with us. We don't have very good embryologists. We need very good embryologists so that every embryo is frozen in one straw separately, and then it can be transferred. You have to do pooling. What you can, I had a patient, I'm not lying. 48 embryo transfers were done in 6 embryo transfer cycles. And in the end, in 2 cycles, donor and self-oocyte. This was a young Afghani girl, maybe 31 or 32, where they used to do 4 embryo transfer, then they went up to 6 embryo transfers, they went up to 8, and they were all blastocysts they were writing. She never got pregnant in one. And we did, I'm not speaking about us. When she came to us, she said, what will you do that I can have a child of, I mean, I don't care about donor because already I've had so many donor embryos transferred. One embryo transfer and she got pregnant and she had a live birth and she's come again for the second child after a year. She's gone back to her country. So, you have to make good embryos. Why embryo pooling? You have to do embryo pooling of good embryos. Embryo pooling we also do by duostimulation. But one plus one, every straw will have one good embryo and every straw will be graded, whether it's A, B, AC, BC, CA, CB, whatever it is, every straw should have this grading. And whatever the grade may be, you still will transfer only one blastocyst at a time. You only collect 2 good quality embryos to transfer rather than SCT. If you say they are truly good quality, then they will give you a 50% multiple pregnancy chance. And if you do a single embryo transfer, you will have a 50% chance of a single pregnancy and 50% chance of a failure of the cycle. I think even in DET, you will have 50% failure, but out of the ones pregnant, you will have a 50% chance of a multiple pregnancy. So you choose what you like. फेलियर तो दोनों में होगा, एससीटी करोगे डीईटी करोगे, पर ट्विन प्रेगनेंसी डीईटी में ऑलमोस्ट 50% में हो जाएगा if they are good quality embryos according to the true evaluation of an embryo.
And ma'am, when will you call it a RIF? 4
Now
single
the
embryo
definition, you tell the definition, Tejashree, you know what is it now. One is that we have now calculators where we say for this patient, we have to know 2 things, the patient's age, and number 2, we need to know that center's implantation rate. And once we know the center's implantation rate and the age of the patient, we can calculate how many embryo transfers should be done before we call that case as having recurrent implantation failure. For younger women less than 35, it is still 2 embryo transfers. I mean, after 3 embryo transfers, you will say recurrent IVF failure. But in a woman who's 40 plus, 6 embryo transfers fail, then you say it is a recurrent failure. But if it is a tested embryo, then 1 embryo across the board, whether she's less than 35, less than 45, 40, or more than 40. In all, 1 single embryo transfer failure, you will call her as RIF. In all cases, at least in younger women with good prognosis who had more than 60% chance of conception on 1 embryo transfer, there also, if 2 embryo transfers fail, then you call it RIF and you can start counseling and investigating for RIF. Read this, Ashri में बहुत अच्छा guideline निकला है. So this is Garima Agarwal, no? Just read, open the Ashri guidelines for RIF. And they've written very clearly how do we define RIF and in different age groups and according to the center's implantation rate, what should be the RIF. 60% is the cutoff in that. If you have a chance that 60% the woman should have been pregnant, then you start investigating for RIF. So I would expect all of you to give answers to the questions which Dr. Tejashree has made with a lot of effort and thought put into. She read my lecture and then she made these questions only to have very clear-cut numbers sticking to our mind that we are absolutely clear of what we should be doing. So please fill in those and put it in the chat. I'll be very happy if I can get all the answers from all of you so that will encourage me to work further on presentations. Okay, thank you.
Thank you, ma'am. Thank you so much for all the effort that you put in each time. I'm sure everybody is going to miss your life lesson as well. So next time we'll have
Oh
a
my
slide
goodness,
on
I
the life
forgot the
lesson.
life lesson this time. Well, the life lesson I'll just give in one word. I feel that, expectation should be as little as possible and acceptance should be as much as possible. It'll start making you very happy. I mean, don't expect anything. Your birthday, your husband forgot, never mind. I'll remind him and we'll go and celebrate. Anything anyone forgets or, I mean, does which you feel that, he should have looked after better. Accept. Don't expect anything. Just एक्सपेक्टेशंस को जीरो कर दो तो फिर तो भगवान बन जाएंगे और this is one thing which I always feel I want all of us to know. I am a follower of Shivani Didi and this is her teaching that अगर एक्सपेक्टेशंस कम कर दो और सब चीज़ें एक्सेप्ट करने लगो, अगर उसने कुछ किया है जो तुमको ठीक भी नहीं लगा, एक्सेप्ट कर लो तो जिंदगी बहुत अच्छी हो जाएगी. All right, life lesson. You reminded me. Next time I'll make a slide of the life lesson, Tejashree.
Yes, thank you so much, ma'am, and good night, everyone.
Good night. Good
I
night.
think we are going to
Thank you,
have the
Vishal Dave.
Thank you, ma'am.
and
Thank
we
you.
are going to have the lectures alternate Thursdays here on.
Yeah, we can do that because I've again got a lecture on Sunday. Then on 25th, I've got 2 lectures to give. So I'm getting crazy preparing for all these lectures. So maybe we can take one Thursday a break and this will come on the website. So you all can retrieve it from the website. Okay. All right, Vishal, thank you very much.
Thank you, ma'am.
Yeah.